Hi, good morning. My name is Ava Nicole, and I am a recent graduate here at UCSD, where I received my bachelor's in public health and a minor in biology. But before I start, I do want to say I'm a little bit nervous and intimidated to speak along with all of these great speakers today. And I also like to recognize my co-authors who are also present here today, Dr. Laramie Smith, Brianna Thrift, and Uni Park. So my presentation is collective effort by myself and my mentioned colleagues, and we all contributed to the work comprising this presentation. So depending on your outlook, I'm either the lucky or unlucky author who will take the lead on today's presentation. All right, so as the title of my presentation suggests, we're going to examine some of the different factors that affect women's engagement in HIV treatment. So, okay, first, I'd like to provide some background information. Research shows 1 in 4 people living with HIV and AIDS in the US are women, and 19% of all newly diagnosed cases in 2015 were also women. Ethnic minority women living with HIV and AIDS experience more disparities in AIDS-related disease burden and mortality due to late presentation and early discontinuation of ART. African American and Latina women, in particular, experience higher rates of mortality after AIDS diagnosis. They also have smaller declines in AIDS-related mortality rates than any other HIV-positive population since ART, or since HAART. The goal of our research is to better understand the different factors that contribute to treatment disparities among women living with HIV and AIDS. So for our method, our study consisted of a total of 25 interviews with women living with HIV from Christie's Place, which is a local San Diego not-for-profit organization that provides resources exclusively to women living with HIV and their families. So the interviews were conducted anytime between January and April of 2015 by our study staffs in order to have an unbiased response. These interviews were also audio recorded and transcribed verbatim, and the transcripts were then provided to us for qualitative review. And we went ahead and identified emergent themes using the framework method, and we also used the social ecological model shown here as a way to interpret emergent themes as individual, social or relationship, and community level factors impacting women's engagement in HIV treatment. So our data reflected that 47% of the study participants were African American and 27% were Latina. And the 25 participants averaged being HIV positive for about 11.4 years. And while the data also reviewed that while 90% of them are currently taking ART, only 59% report over 95% adherence to treatment. So in other words, only 6 out of 10 people were adherent to treatment protocols. So therefore, the question becomes, what factors and what themes do we see emerging to explain the low level of adherence to treatment? Now I'd like to further explore the different factors like individual, relationship, and community to further explain how they influence treatment engagement. So there are 3 factors associated with the individual level. The first is HIV diagnosis as a traumatic experience. So traumatic responses were to be diagnosed with HIV were observed among the majority of the women from the study. And many women were severely ill and they were hospitalized at the time of their HIV diagnosis. And because HIV was a highly stigmatized disease, others diagnosed prior to the HAART era described experiences of dismissive and neglectful treatment from their providers. As a result, it increases experiences of internalized stigma and anticipated stigma from others. So as a response, what many women described isolating themselves from others and even deprioritizing or avoiding treatment altogether. So I have a quote here, and it states, quote, "So trying to kill myself, I was just trying to do that so nobody could find out what happened. I felt ashamed. I feel dirty. I feel like, oh my God, nobody will ever want to touch me," unquote. So the second individual factor is HIV identity salience. The woman who viewed HIV as a salient part of their identity described treatment and support as a positive factor, improving their quality of life. On the other hand, women who did not view HIV as a salient part of their identity tended to reflect on the more negative quality of life experiences like unemployment, substance abuse, and homelessness as barriers to HIV treatment. So in other words, there was a positive relationship between salience and treatment. The more salient HIV was a part of the person's identity, the more treatment was viewed as a positive factor that improves their quality of life. So the last individual factor is the burden of non-HIV comorbidities. Example of this include depression or diabetes, and they were discussed as making it more difficult for the women to engage in HIV treatment and to adhere to their medications. So there were other competing priorities such as relationships that are abusive, and substance use and addiction also caused delays in receiving HIV diagnosis and treatment initiations. So as a result, this compromised both their mental health and their self-esteem. And therefore, the data revealed a negative association between non-HIV related comorbidities and treatment. The more non-HIV related comorbidities are present, the less likely it is to receive early HIV diagnosis and to begin treatment. The next level in the social ecological model we considered were the relationship factors, and the first relationship factor is disclosure of HIV status to their family members. The process of disclosure to their family members and friends resulted typically to rejection and discrimination. So a lot of women try to avoid disclosing their status as a way to protect themselves against negative reactions. But regardless, the disclosure process in general increased social isolation and limited their access to HIV-related resources. However, romantic partners and children were two notable exceptions, and disclosing to a partner was typically described as a positive event, especially when the partner was also HIV positive. The woman felt like they had a source of social support. And a lot of women describe their children and their grandchildren as a motivating factor for care, even when disclosure was absent. So an evidence of this theme is reflected in this quote. So the second relationship factor is knowing other HIV positive people. Many women reflected on the importance of knowing other HIV positive people, especially other HIV positive women. And these relationships were viewed as a source of motivation and social support for them to stay in treatment. The final level in the social ecological model we considered were the community factors, and the first is religion. So having a sense of faith was considered as a motivating factor for engaging in HIV care. And therefore, there was a strong positive relationship between faith and HIV treatment. Also, it was interesting because for those women who were more engaged in the church communities, they did not disclose their HIV status due to anticipated stigma. And as such, while having a sense of faith positively affected their treatment, direct forms of social support from their religious communities was actually lacking. So the second and final community factor is the the role of the HIV providers. And this engagement from HIV care occurs when HIV medical providers were not supportive or not addressing the individual's needs. This was especially true for patients with mental health issues, which were not identified by the providers. And on the other hand, the woman described when there's a strong bond or trust with their medical provider, it's critical to their HIV care engagement. It's also important to realize that for a lot of these women, when they don't disclose their status to anybody, their medical providers, including Christie's Place, are often the only resource they have for anything. So I have another quote here from one of the participants that shows the importance of having positive providers. So, quote, UCSD and Christie's Place are like my family. I was in a sad place, so it really changed me because I felt like I had someone who had my back, who I can trust, who I can talk to. And in conclusion, what our study determined was that the levels of the social ecological model partially explained the disparities in treatment of ethnic minority women with HIV and AIDS. And finally, I'd like to thank you for everyone for being here and to thank my colleagues and those who supported us. So at this time, I'd like to open up the room for questions and discussion.
Thank you. Good job. So yes, the session is open for questions. Thank you for presenting this important data. Nice job. Sergio.
Hi, I'm kind of short. So hi, it's a great talk. So it seems like the healthcare providers, right, that's pretty pivotal or key in terms of the interactions and kind of the feelings of some of these women. Mm-hmm. So did you guys have a chance to look at when there was a interaction with a healthcare provider that was either also a woman or was of the same race or ethnicity, more positive kind of interaction that you guys could see in maybe some of the transcripts?
So I actually would like my co-authors to have a chance to talk. So if you don't mind, I'm going to have them to come up and speak.
So I can answer that question. In the sample through our qualitative interview guide, we did not explore concordance of gender or race ethnicity of providers and patients, but I can say kind of having a background knowledge of who the providers are that they were talking about, that there wasn't necessarily concordance, but what mattered is that they felt listened to, that there was a genuine expression of empathy and understanding, right? That they felt loved, right? That feeling, that was the biggest reflection is, that's my family, I walk in, I'm loved there, people care for me there. And I think bigger than the concordance issue is the takeaway that for many women, the stigma, having such a self-isolation process, that provider or the people at Christie's Place are literally the only people who know that HIV is a factor in their lives. And so being able to build that patient-provider relationship between those women and their providers is really an important theme that came out through the data.
Thank you. Are there any other questions from the audience? Yes.
Hi, thanks for your talk. So considering that lots of the women in your study did not feel able to disclose to like members of their church, would you consider delivering education programs to their churches?
So I think Christie's Place, there were, in some of our participants' interviews, there were people from Christie's Place who actually came to the individual's church community and actually provided education on HIV. So, but I did not see a lot of that happening, but there were a few examples that happened. So I don't know if that answered your question.
So Eva, can I ask a question? So looking through your factor, it seems like to me as a factor that affect cisgender women are similar to factors that affect transgender women, like stigma, violence, and feeling ashamed, and not having a strong social net to talk about. Do you or Christine Place offer specific navigator for transgender women as well, or or do you plan to expand this program or your study to include transgender women?
I'm actually not sure because I don't work at Chrissy's Place, but I think they should.
There are a small percentage of women who access services at Christie's Place that are transgender, and Jay and Martha have done engaged in peer-based patient navigation with them. We're actually very excited about a new partnership that we have with Trans Family Support Services that's going to commence in January, where we're going to be engaging in new trans-specific programming at Christie's Place. So stay tuned for more news on that.
That's excellent. Thank you so much. So, if there's one more question, we can take it. Otherwise, I think we are ready for our break. So before we go to the break.